for everybody on the Zoom, for the program leadership all here, and for everybody on in the sim stuff too. Okay, today I'm going to be talking about second victim syndrome. I think it's an important topic just to think about in general because it's something that is quite pervasive, especially in the last year or so, because big things happen then. So who has heard this phrase and instantly felt fear? Remember that guy you saw a couple days ago? Nobody wants to hear that phrase and kind of think about, oh God, what happened? And it could be something as benign as like, oh yeah, he came back and had a totally different complaint, or he came back to say thank you. But most of the time we're like, oh God, how did I mess up? And I guess for everybody here, raise your hand if you have ever made a mistake at work. If you've ever went home and felt guilty about it. Dreaded coming to work the next day as a result. Replay the case in your head, maybe, or been scared you were going to lose your job. And for the audience at home, everybody here raised their hands. So basically, what is second victim syndrome? In the year 2000, Dr. Albert Wu, he is a physician at University of Minnesota, he described the effects of the adverse events had on the healthcare providers. Basically, the thought is an adverse event happens to the patient. They are the initial victim, the patient and their family, and the second victim is the provider, the healthcare professionals that are involved in their care because they are also affected. These include patient safety or medical error events, even including incorrect medication doses, misdiagnoses, incorrect medical management, harm during the procedure, several other things that I'm sure we can all think about. And oftentimes these are unforgettable and they can leave lasting emotional scars on the providers as well as the patients. The symptoms of second victim syndrome include anxiety, depression, guilt, sleep disturbance, loss of confidence in your practice, decreased job satisfaction. It actually looks a lot very, very similar to burnout and can contribute to fear of losing your job. It can change your practice styles, change and prompt you to change even your career. It can cause some isolation, depression, and even potentially suicidality. It's also been shown that having this kind of overwhelming guilt can also contribute to being involved in another medical error, or even a patient safety issue because you're kind of in your head and you're thinking about this error, and because it changes your practice style or something along those lines, you're more prone to an error. Residents in particular are particularly vulnerable to second victim syndrome because we're in the learning phase of our careers. We're more prone to error and we're more malleable in our practice styles. So there's also high clinical demand. We don't sleep that much, a lot more fatigue, and we're thrust with new responsibilities. And sometimes we're moving far, we lack a support system. So one study showed that the prevalence of fourth year students, medical students involved in a medical error was as high as 78%, and residents, 98%. A survey of more than 3,100 physicians from the United States and Canada found that 81% of those who had been involved in a clinical event, such as a serious error, a minor error, or a near miss, had some sort of degree of emotional distress. These are the six stages of recovery for, as theorized by Dr. Wu, after one of these issues, one of these medical errors happen. And these are kind of typical for second victim syndrome. And this is kind of the course that everybody goes through. So I'll go through this step by step as well. The first is chaos and accident response. In this stage, it's right after the event happens, there's confusion, there's turmoil, and the practitioner themselves becomes more confused and ineffective or on critically ill patients. When in the past, they might have been more in control, more self-assured about this, because they're asking themselves, why did this happen? What did I do wrong? How could I have done this? The next part is intrusive reflections. This is when, you're kind of reenacting the whole thing, playing it up in your head. You're haunted kind of by these reenactments. And you have these feelings of internal adequacy, periods of self-isolation, and you ask, how could I have missed this? How could this have been prevented? And this is often where the provider feels a loss of confidence, feelings of isolation, and has the increased difficulty focusing and concentrating. Then the next is restoring integrity. This is more kind of the front facing. This is the stage where people say, what will others think? Will I ever be trusted again? Does everybody think I'm an idiot now? How much trouble am I in? And it's during this stage that providers will often begin to seek support from a trusted individual, a colleague, a supervisor, family members, friends. And oftentimes without positive support during this stage, providers can get have incredible difficulty moving forward in their recovery. Providers often do not want this error to define them as a physician, and sometimes they describe an inability to move forward as kind of like grapevine gossip. You know, they hear people talking about it, and that kind of feeds into it as well. So this can often happen along with the previous two, the intrusive reflections and the chaos. This can all happen all at once, and just something to kind of keep in mind after a medical error, just to watch out for. Often, people will try not to discuss the topic with the provider because they don't want to try and reopen an old wound. But this can sometimes be harmful because the person might be seeking out some sort of kind of camaraderie among their physicians, and it might be worse. You know, they think people aren't talking to them because, you know, they messed up, they aren't trusted anymore, and it isolates the physician more. So it's often very physician dependent, provider dependent, but kind of balancing the need to handle emotions, seek help, avoiding isolation is key. The next step, the fourth step, is enduring the Inquisition. This is more kind of the admin regulatory phase. This could be in the form of RCA, peer review, M&M, and this is where things are a lot more discussed. And support here is absolutely key because oftentimes these cases are brought up again and again and again, and it is a little bit like reopening an old wound. The provider somewhat has to come to terms with the practical elements of the error, including as far as potential litigation and job security. And it's important to keep in mind that in many institutions, these items, including the RCA, peer review, M&M, these are meant to help you and others improve. It's not necessarily a punitive measure, which is often hard to see sometimes when you're kind of beating yourself up about something. The fifth phase is obtaining emotional first aid. This part is often limited by legality. After you start the initial phase, and you go to seek help from your colleagues, you might be limited in what you can say if there's some sort of pending litigation. But it's very crucial to have some sort of support in the form of friends, peer counselors, therapists, and a vast majority they found of second victims kind of quietly wait and hope that somebody will offer support. And many express concerns about not knowing who's a safe person to confide in. But approximately 1/3 of second victims seek support from loved ones, but indicate they're cautious when doing so because of privacy and legal reasons. So it's important to kind of identify people who are going through this so that you can reach out and support them, even if they are not coming actively to you. And the last is moving on. This is separated into 3 parts in the whole second victim syndrome literature. There's survive, thrive, or drop out. These are kind of the 3 stages. There are some that do really well. They learn from the entire scenario. They become a better physician. They grow from the experience. And this is absolutely what we all want to achieve. There are those that survive. They stay, they cope, but they're haunted by this, and they may not be quite the physician that they were prior to this event. And the last is the dropout. There are some physicians for whom this kind of wrecks their entire career, and it may be from a litigation standpoint or even from an emotional standpoint, and they kind of retreat and potentially leave the profession, move to a different practice location, change their professional role because they can't reconcile their involvement in the clinical event, even if they have ongoing social support from supervisors or from peers. So what can we do? I'd say here that support is key. Many of the papers that I read discuss systemic wellness programs and resiliency training. I think it's very important to recognize that this is a prevalent problem that may not have an easy solution. We've had some previous lectures on these kind of topics, including Wendy Dean's lecture earlier this year on moral injury. And we discussed there that we're innately resilient people, and I strongly believe that. Despite facing sick or dying patients, we still get up, we come to work every day. So it feels like kind of a slap in the face to be told, be more resilient. And that's how you get through this. Studies have shown that the most effective management for second victims includes support of the providers by peer colleagues from within their own specialty. Support from friends, significant others, and supervisors are important. And most providers prefer support from a trusted colleague because they understand what you're going through and they understand the practice environment. Receiving support from a colleague within your own specialty has kind of the shared understanding about the complex nature of the patient care, and it normalizes the situation for the provider. Peer support teams are also in place and are trained to provide emotional first aid, and these have been found to be incredibly beneficial, and I'll talk about one for the HHC system in a little bit. M&M and patient safety conferences often can help as well following the events during residence training because they can help kind of rationalize the things that occurred and help kind of provide a path forward. So my solution here is to be vigilant. There's not to add another duty to everybody's plate, but if you see somebody struggling, say something. Reach out to your seniors, your chiefs, your APDs, your PDs, hospital admin, attendings, mentors, advisors, anybody. Because we're lucky, we have so many people here to look out for each other. And many of the key steps to recovery, as we previously talked about, involve a lot of other people. So I think that's truly where we at Kings County, Downstate, and other programs can really shine. So I also say the golden rule: treat others how you would want to be treated in a similar scenario. Would you prefer sympathy, or would you prefer to be left alone? See if that works for the other person as well, because, you know, a lot of people tend to react similarly and treat others how you would want to be treated. I think also it involves kind of culture shift in the face of emergency medicine as a whole. A true test of patient safety culture comes immediately after one of these events occurs. The initial reaction among your colleagues can kind of dictate what the culture at a current institution is like. You know, if you try to hide the event, you know, the provider may feel more ashamed, and this is not the right thing to do. If you as a person, you know, are very open, you feel that your admin will be supportive and you're more likely to disclose it, this is kind of an indicator of a good practice environment where you trust your hospital, you trust the people that you work with as well. Some places have suggested some sort of rapid response team or some sort of institutional team just to support these providers going through burnout or second victim syndrome. And I think that this is a great possibility and a great step, but in my opinion, kind of a stopgap to culture change, because what we kind of want to move towards is what's called in literature just culture, which balances the need for an open and honest reporting environment with the endpoint of quality learning environment. So rather than pointing blame at an individual provider, a just culture encourages individuals to disclose medical errors in a supportive environment to help promote rather than impede the culture of safety. The best way to avoid second victimhood is obviously in the first place to avoid patient harm in the first place, but to borrow a cliche, to err is human. The healthcare field is working hard to change the systems to avoid the commission of errors, Swiss cheese model kind of thing. But until we are able to get to a completely harm-free healthcare system, we need to acknowledge that there are going to be issues, there are going to be mistakes, and we need to acknowledge that and help out our colleagues. This will kind of help mitigate the damage to both the victim and to the second victim, the providers. This is the program that I mentioned at HHC as a whole. Helping Healers Heal is a program that was initially created out of the University of Missouri by Dr. Scott. She was the one who initially kind of laid out the 6 steps, the pathway to recovery. And they created a program to help providers access resources for peer-to-peer support, mental health, debriefing, both cold and hot, after something happens. And this is something that, you know, we can all get involved in. Dr. Wei, who works at Central Office, brought it from LA to the HHC system. And I think there were a couple of lectures last year pre-pandemic, and certainly something that we can all get a little bit more involved in to kind of improve the culture and throughout the entire hospital to kind of mitigate errors. And I just want to talk about some related concepts as well, because we hear a lot of these words kind of thrown around in all of these wellness lectures that we get. So I kind of want to tie it all together to put it into context. So we have a couple of different things. There's a missed case or a medical error, or there's a harmful event. And this can be something as small as, like, you know, a patient that you saw pass away and it kind of really, really hurt you, or like a PEDS case that was really rough. This doesn't necessarily have to be a mistake. It can just be a hard event. And these are two kind of common sources of moral injury and second victim syndrome. Okay, good, it popped up. We often kind of tie the harmful event, the sad event, to moral injury, and that's kind of the systemic kind of chipping away at a provider's feelings of moral fortitude after something harmful occurs. And the missed case or medical error kind of engenders the second victim syndrome, like we discussed earlier. This can often lead to burnout, both of these things, kind of the slow, insidious process of the moral injury versus the second victim syndrome after a large case. And then this can ultimately lead to compassion fatigue, and that's something that I think a large number of us can probably say that we have experienced at least once, where you're kind of overwhelmed and you just feel like you can't contribute anymore compassion-wise to a patient's case. In your head, you're like, I want to feel so bad, but I can't do anymore at this time. All I can do is think about what's going on with me right now. And this is something that can lead to the things that we were talking about: surviving, thriving, or dropping out. My current solution at this point, I think, is rather than pushing people towards burnout and dropping out, perhaps we can try these kind of situations: debriefing, helping healers heal, therapy, these kind of things. Perhaps hot and cold debriefing. Perhaps these things can provide kind of push people towards the thriving, surviving section of the second victim syndrome, and stop the burnout and compassion fatigue that would happen from stop right here. The burnout and compassion fatigue that would happen from the dropping out section. So, okay. At the end of this, it's important to remember mistakes are inevitable, but you're never alone. There's always somebody to reach out to. I want to thank Dr. Jane Kim for being my sounding board through a lot of this lecture and giving me a lot of great input. Doctors Chow, Ahmad, Dr. Berlin, Dr. Willis, Dr. Stetz, Dr. Wolf, and the entire wellness lecture team for helping me out through this. And does anybody have any questions? Anybody in the audience here? Anybody elsewhere?
It's nice to see that the culture has changed. When I was training back in the 70s, boy, if you made a mistake, everybody knew it, and you were the guilty one. And and very little support at that time. Certainly, you'd never see something back then of helping healers heal. Never, especially from HAC, right where I worked and I trained. They would talk about maybe, having the big picture, but they would go after you. And I saw people lose their jobs because of mistakes that weren't totally theirs. And several times. Yeah, and so it isn't nice that there's a change, and the emphasis is more on also protecting the environment, making that better, as well as helping healers heal, and not blaming the individual unless it's something really terrible.
Mm-hmm.
Just thinking of why we have duty hours, a lot of that stemmed out of the Libby Zine case, right? Yeah. The residents who took care of Libby Zine were fired. They lost their job. They lost their residencies. I mean, that was the culture, right? And that was a culture to make things safer for patients. And even then, it was let's blame the residents here, and not the lack of there being attending or the private attending who sent the patient in with limited information. So it's important to recognize this change. And even our last case, right? That was a blatant error, and it's not about focusing on the error. It's about focusing on how to prevent that error in the future and making sure that not blaming that individual, but really trying to prevent the errors and supporting our colleagues who may or may not. We're all going to make errors. And sometimes you're just going to get lucky. Most of the time, if it's not worse, it's just because of luck. I definitely feel like I'm lucky a lot of times that I make a mistake, it doesn't hurt a patient, or I just caught I happen to look at something at the right time that I don't normally look up, and you find it. But you have to recognize that we're all going to make mistakes, no matter how good we think we are.
That was going to be my comment, and kind of, first of all, great presentation of what Monisha said, that this is kind of a newer concept, but it's definitely not a new concept, as we can hear from Dr. Gernsheimer, Dr. Schechter, but I think rightfully so, it's getting attention, it's getting labeled, and we're dealing with it in a different way. I would say for everyone on Zoom, all the residents listening, expect that you're going to experience this if you haven't already. It's part of medicine, unfortunately. You're dealing in high-stakes situations, you're taking care of sick people, and as was implied in both the last presentations, you're going to make errors, unfortunately. Hopefully you don't. I hope you never do in your whole career, and please let me know. But you're going to, and I think it really depends on, in terms of the thrive, survive, or drop out, is how you deal with it and how the place you're working deals with it. So, when you leave here, looking for a place that's going to support you, but also identifying a support system that when this does happen to you, who you can go to. And I think Manish did a good job of kind of talking about different people you can. You may prefer talking to non-medical people, talking to your mom who's not in medicine and will love you and tell you you're a great person no matter what happened. Or talking to a colleague who can kind of work through that case with you, or talking to both and multiple different types of people. So it's important to identify those people you can talk to about these things, because they're not easy. What comes with this is shame, and you're going to feel shame, but it's about how you move past and through it. It's the important thing. So kind of figure out how maybe you're going to deal with that if you haven't already. And I'm a person you can always speak to.
It's everybody able to hear that. Dr. Kim says, it's an old concept, but recently labeled and talked about and recognized. And for those who couldn't hear Dr. G or Dr. Schechter, sitting a little bit further away, distancing, they mentioned they credited how far our culture has changed, which is excellent, from the times when, if they made a mistake, they would be ridiculed. There was shame involved. And oftentimes, as Dr. Schechter mentioned, the reason that we have duty hours, the residents who kind of came before us in that case, they were fired and their jobs were at stake because of a case that came to help all of us. So just something to keep in mind, and also with the M&M that he just presented as well. So yeah, thanks, yeah.
Thank you.